Hello everyone. So good morning once again. I am back with one of the newer video on HMIS, Directly Health Management Information System. Even at every program to manage this program, likewise in the every in the government system to implement that uh, HMIS is very important over there, playing a very important role. And it was like as previously, directly it was paper based. Now we are shifting from as digital innovation is coming. So we are shifted from paper to computer based, app based to capture and management health and manage the health related data. So HMIS is directly coming under government statistic division of Ministry of Health and Family Welfare. So in this directly likewise implementing any of the research program at the ground root level, we are collecting the data, organizing and analyzing decision making policies. After this formulation will be over there. So the main role is likewise data collection. So from from national division to till at the you can say that a smaller part of our health facilities, that is sub centers, we are collecting the data from their sides, and it's coming from the CHC, and CHC is compiling, and after the compilation of these data, this goes to the state as well. While going previous to going to the state, so pre-DHS and DHS, Health Society, under the review of likewise the chair of DHS is district magistrate of that district. So data review will be over there, and dashboard based on the indicator and dashboard, the discussion will be over there. So the most important part under the HMIS, likewise key backbone of our implementation. So after getting data collection, monitoring and evaluation team work on that. Based on these indicator and analysis, resources allocation, fund allocation will be provided, and the surveillance directly on any of these surveillance will be put, as well as health strategic planning based on these only we are able to prepare. Quality improvement is one of the most important target and part of it. So recently government have initiated that one of the quality improvement meeting has to be done and based at every CHCs. Uh, Apart from CHC, as district women hospital and DH as well. On this, we will discuss about various indicator based on HMIS as well, and specifically the UPHMIS also included over there. After this, reporting and finalization will be over there to monitor these quality performance of health services. HMIS is very important playing a role over there. Apart from this, as we have fixed our sustainable development goal, indicator number 3, that we have to achieve IMR, NMR, under 5 mortality rate. Apart from this, MMR as well. So to keep an eagle eye on that all the indicator and to track it out that whether in which way we are going, so that all is needed. So for this, it is a very important part. And before you starting HMIS, I will recommend you all that to please go through that dynamic of healthcare services in India. That report has came in 2020 and 2021. Apart from this, if you will go through that RHS statistic as well, so it will give you a clear picture on this. So let's start. So definition, as we have discussed as in some of the outline, that resource allocation, surveillance and planning, quality improvement. So that all the aggregation and gathering and analyzing that all the information, and based on this taking action and in the way to improve the performance of our health facilities and health system. So that's key. The mandate to ensure that there is a continued flow of good quality disaggregated data, help population healthcare services to assist local planning, program implementation, management, monitoring, and evaluation. The main part, as we have discussed, the backbone is monitoring and evaluation. So we have to take care of that. While principle of data reporting has been set it out, that all these resources has been allocated, as well as responsibilities has been allocated to a dedicated person at sub-center level. It's came for the ANM that they have to submit to the BPM, and BPM will process on the behalf of either himself or any other operator or supporting hand over there. From the CHCs, that nurse mentors has to be collect on this, and BPM has to verify this data from the labor room, labs, OPD, IPD, pharmacy, that all the data he has to do all that. After that finalization, he or she has to be upload the data. The data has to be updated in likewise in numerical form only. No cell has to be planned to remove this error. So the data flow comes from likewise the one of the picture at the below this PHC data set. So that is sub-center, and it goes to the PHCs, and as sub-center refers to this, and PHC come under the CHC, and CHC after the finalization of the data, it goes to likewise the DPMU. All the CSCs reports to the district DPM over there. As after this, DPMU will report to SPMU. Before this, DPMU has to be implement as DHS meeting, pre-DHS as well as DHS under the supervision of district magistrate and CMO. And based on this, SPMU also does their review meeting and national as well. So the concept is key, the data which is coming, that has to be processed. So based on this, we have to design the organization with reference in context. So it will be convert in the form of information, and based on this information, reaching to at any of the extent to drag it out any likewise that convert to the knowledge. So, like data is number of pregnant women in an area who received skill birth assistance in the delivery. So that is one of the data. Now the information it's converting that the percentage of pregnant women received skill birth assistance and percentage of pregnant women who were left out. Like basically left out is that who has not received the care from skill birth attendant. So that's come for the information, and based on this information, reaching at any of the output, so that's come under the knowledge. Likewise, why this pregnant woman, the number of extent of pregnant women has been not received that skill birth attendant during the delivery. Why they are left out, and why their home number of home deliveries is more. Why the pregnant women are not consuming this iron, folic acid, or calcium. So that's come under the knowledge. Based on this knowledge, you can reach out to any of the extent for policy briefing and action taking on this state as well as district or specific to the PHCs and CSC as well. So data collection, the data process is likewise the first system is coming from the data collection. So the data has to be collected from this starting from sub-centers to PHCs, CSCs, and DPMU to SPMU to the national. So the dedicated person and responsibility has allocated with them, and this all has to be ensured that no duplicacy and no error has to be found over there. So in the fourth set of this series, when we will be discussing, so we will be also discussing this HMIS format in which all over the India data is getting collected. So we will discuss in this that the same format has been given in the monthly reporting formats. So the line listing format of births and line listing of deaths, district monthly stock. So these all the things will be there. We will discuss in detail. So, likewise, data entry also we have discovered. So, this all the responsibility has been allocated to the specific persons, so they have to fill it out. And data authenticity and authorization, likewise, whatever the data is coming, so directly without cross-checking directly, we are not going to upload it to it. So it has to be authenticated, and the copy has to be also uh, saved at our end, and the file and documentation has been maintained, and verification has to be also be done over there. So data analysis, likewise After getting all this data, when DHS is going on, so based on these monthly data, so the information and flowcharts and the form of tables and graphs, pie charts, and if this has to be that has to be converted, and then it has to be presented in district health society, and these will be also used for this budget allocation and PIP as well. So what is indicator? So why do we need indicators? Because likewise ki, this does not describe this status of immunization or any of the service delivery. So indicator has to be very precise, which we can going to be used at which can get convert in any of the information, and which will be going to directly interlink with our all the sustainable development goal, or sorry, or that will directly going to help out um, to improve the quality of care at our CHCs, PSCs, or our healthcare system or health facilities. So, likewise, ki, we cannot compare the raw data of service delivery of one facility with another facility over a time, because likewise ki population and OPD, IPD, that all will be different. So in this context, the raw data has to be always converted into the information, so then it will be going to be used, or data can be going to be processed. And on the behalf of the same, WHO has been defined that indicators are generally defined as variable that helps to measure the change directly or indirectly. Any of the variable which is going to help out to measure the change either directly or indirectly, that will come. So in deep we are going to discuss about that numerator, and in the second series when we are going to discuss, so how you are going to check out maternal mortality rate, infant mortality rate, under 5 mortality rate, and neonatal mortality rate also is over there, and child death rate, immunization is also over there. uh, EIBF percentage is also over there. So complication that all we have to measure out. Stillbirth we have to measure out. So the definition has to be likewise key denominator should be known before going to that one. Sorry. So indicator usefulness of indicator is that key serving an observable marker of progress toward the defined target, which was the basic part, and likewise key to track out whether we are implementing or in which phase we are going, what is our progress, so that tracking that our progress is very needed. So on monthly basis it's it is going to be checked at every DHS situations, and serving as a measure of change over time, what the situation is changing, and what is the current situation, what was the past situation, and what we are expecting in the upcoming days. So that describes over here, and as well as it's also provide a broad range of condition through only a single measure, while going through capturing a data of one indicator give a an bottle opener, eye opener, that gives a vast area of information on this. This also provide as a stake for the healthcare facilities, in which they can compare themselves with what they are what the others doing. Likewise ki in DHS review meeting, all this medical officers and block BPMU staff has to be over there in this DHS. So while when the data is going to present over there, so the comparative they can compare with our neighboring blocks as well. What is the percentage, and what is the quality of care, and what is the data is showing. So that can be done. So the data has to be likewise key indicator has to be in the form of raves, must be reliable. Apart from this, indicator should be appropriate, valid, easy and feasible, sensitive and specific as well. How many occurrence are them it's going on, like a top line numerator activities and intervention and event. So morbidity, mortality, as well as human resources we are tracking out. And under this general raw data in the numbers, we are going to collect the um, OPD, IPD data and ANC, PNC's data deliveries. So that all will come over here. So the bottom line denominator is the population as at risk, size of target population at risk of the event, what group do they belong to? The population at risk, we are discussing directly for this population at risk. So from which group they are belonging? Either they are general population. In the general population, what is the total? If their catchment, hard to reach area, uh, uh, targets likewise in the specific to the immunization uh, parts. Specific peoples will be over there, they are not ready for the immunization, so they are will be the population at risk. What is the gender population? If we are talking in the terms of immunization, so it might be up to till the immunization uh, period only. If we are discussing about the number of home deliveries are higher in any of the specific village or block or district or state, so the gender population will come pregnant women, that will be adult one. So age group also we have to tracking out, and cases and events, episodes happening uh, in per specific that time period. Likewise ki if we are discussing about the measles or lymphatic filariasis, so that the cases and event happening in that particular time period and time bound, that has to be taken care of that. So a rate has to be calculated. A rate we have to track out. So this is just an overview I am giving over here. So that's why in the when we are going to discuss in the details in the second series, so that will be a great picture and image that how we are doing the calculation and how we will going to measure this. So this is just an example has been given to how to calculate that low birth weight rate. So this is the formula has been given over here, and rate, you can see the difference over here. So the rate calculation per thousand based. So in this, likewise, any of the example can be taken for the over here. It has been depicted by taking the example of diarrhea in a district in X. You can take your own district, likewise in the Gorakhpur is 14.9 after this calculation is coming. So we have to take care of this ki the number of month year here month has been taken, and the total population has been taken, and the basis of this we have to multiply with the pass 1000 in the rate calculation, and directly it's coming for the result of 14.9. While the same thing is the third one example has been given for the rate per lakh. Apart from this, incidence rate of diarrhea, likewise ki, in children. So in children, we have cutoff taken for the 5 year, and total number of cases of diarrhea we have to track out new case of ARI. So if we are going to take out this new case of ARI, uh, divided by this and directly multiplier we are taking over here for 1000, so it will give that incidence of acute respiratory infections. So on the likewise we over here three example has been taken for rate with the multiplier of 3 multiplier 1000, this we have taken over here, and the same thing will come for the rate calculation as well, and this is over here for ratio. The three was taken in single one. So classification of indicator, likewise ki input indicator, process indicator, output indicator is over there. So input indicator is that ki whatever that which we are going to provide, likewise ki the number of uh, HR what we are providing on the per population as per the IPHS guidelines. So in the start of the session, I have said that ki please go through the dynamic of healthcare services in India, which has been published for 2020 and 2021. So it will give you, apart from this, you can also go through that IPHS standard, the newer one which has came. So that will give you a clear picture about this all, about this key HR, number of HRs on the base of population, and as well as the number of beds required based on the population. Process indicator that's key. Activity which indicates directly activities of health services, which will be directly based on input indicator only. Percentage of doctor trained in safe delivery skills. Likewise ki, we are having a lot of training nowadays. So skill birth attendant dakshata, so these all the training should be over there. And output indicator indicates achievement made by specific health strategies. So likewise ki, the movement as well as counseling done for all the pregnant women by the Ashas, so they can be mobilized to have at least four of the ANCs. So that will come over output indicator. So outcome indicator is also on the same background. This also represent achievement of health program. So the output they have received that the ANCs only, and now we are here. The outcome has to become that after receiving this three ANC in the output indicator. So sorry, institutional delivery rate and EIBF, which is going to be taken within the after the just delivery, after the delivery and within the 1 hour of time limit, EIBF. So that will come on the output indicator. Impact indicator. Impact indicator is also directly connected with output as well as outcome. If output indicator is not good, likewise, if woman has not received 4 ANC, if woman has not received, not received, not consumed the iron, folic acid as well as calcium prophylaxis part. So that will directly impact on the that will directly result as an impact indicator in the form of anemia, postpartum hemorrhage, uh, PPH is also there, a different kind of PPH is over there. So, based on this, they can directly lie on infant mortality rate, maternal mortality rate, because if output indicator is not has been processed at the time of period of the pregnancy, so that may lead to any of the complication. If CH is not having to not able to manage that complication, then staff will refer them to the district women hospital. So in the transit might be the death will be going to be happen, or any of the complication, any of the mishappening is going to happen. So these all the indicators over here, and we will discuss once again about this. So all these indicators are interlinked with input indicator. So it shows that key as per the IPHS guideline, if HR is fulfilled at our every health facility, then quality of care will be completed. So the impact will be very less and in the negative form, but it will be resulted in higher in the positive form. So goals, objective, and strategies. So that is directly which we have discussed, that impact indicator, that HR what we are providing, that is our goal. And objective, that which we have discussed, is process indicator over here. Process, likewise outcome indicator. So outcome indicator, likewise key institutional delivery and EIBF is going on here. Strategies is coming for output indicator, likewise ki medical officer or BCPM has trained their ashas to counsel them for the ANCs. So that strategy will come as an output indicator. While process as well as activity will come for process indicator. Input has been taken in inputting indicator, that HR what we are providing. So limitations. So, indicator just is, it's an overview given. So, when we will be discussing that complete HMIS data set, so we will discuss that key more than 150 indicator is over there in the compilation sheet. So, just an overview that in this data set we are going to connect with antenatal coverage, immunization coverage indicator, delivery services, postnatal as well, child and neonatal health indicator, family planning strategies and family planning indicators, mortality indicators, service delivery as well as lab services indicator. So just to not to get in confusion when we were going to discuss complete HMIS format, so the definition has been given. ANC registration rate, percentage of pregnant women who used ANC care provided by skill health personnel, skill birth attendant, or skill like basically trained staffs. So as we have clearly discussed that key denominator has to be very precise and it should be very clear previous to it. So this is like basically total ANC register will come for the numerator. And the same thing when we are going for early registration rate. So early registration, like basically early registration is for birth. So pregnancy when it is going to be registered, or pregnant woman is when it is going when she is coming uh, at the 12th week of her conceiveness, even at the sub-center level, CHC, BSc, at any level where whether at any place of the health system, whether she is going to be registered, that will come in early registration rate. So a TT booster coverage rate, percentage of women who were given TT2 or TT booster, there is a one of the part over here, TT second and TT booster. So during current pregnancy, so minimum 4 ANC checkup rate. What is the percentage of pregnant women who used antenatal care, who has received their care by trained personnels? So IFA coverage rate. So iron folic acid rate, as you all know that ki, prophylactically it is implemented. So percentage of women who were given that at least 100 iron folic acid tablets. So the and rationale is that ki percentage of ANC registration shows that ki early care and level of awareness among community. So that is one of the rationale for this. Percentage of pregnant women receiving any ANC in sensitive indicator of outreach. Percent of pregnant women received either TT2 or TT booster. Those indicate that maternal TT immunization protect newborn as well from the tetanus. IFA is mandatory to be given to each pregnant woman. Even in fact, ANMs were giving that as well. But if it is not going to be counseled in such a way that iron folic acid will create redness of your stool, or it will create a redness on your breast, or if you are going to take with, you should have to avoid taking with male, so because it creates a chelate and it's directly going to be extracted out. So it is IFA will get good level of with citric acid. So it should be preferred with taking with citric acid. So that counseling plays a major role in this. Action to be considered that key low coverage reflect that strategy provided for ANC should has to be reviewed, and that is specific ASHA, that is specific ANM of that subcenter, or even if it is for CHC, then that is specific MOIC, and should has to be discussed and prepared and executed an strategy that why it is going on and how we can overcome this low coverage of ANC. Quality of care, if provided at the very first visit of that pregnant woman of at during her ANC, so she will be going to come at the second as well as third as well as fourth as well. Even she will come for the delivery as well. If she is not satisfied with quality of care at our CSC's level, then it is very like basically not able to move on for second ANCs, then how we can discuss for the deliveries. But in fact, the as per NFHS 5 data which has come, so we can seek about the SK institutional deliveries over high, and previously it was K home deliveries were high. now it is getting managed and under consideration. So we have to take care of this likewise quality of care as at the very first visit of our pregnant woman who is coming for seeking for the ANCs at our facilities. Uh, Based on this, the second indicator definition is coming for the immunization dropout rates. So, rationale for the immunization dropout rate shows that if high dropout is over there, so it's directly likewise it's decreasing our quality of care as well as the lack of interest from the families for the immunization. So this is a very hard to reach area in this nowadays likewise SMOs from the WHO as well as district magistrate as well as CDOs is also playing a great role in this. Now the dropout is very less in the comparative with the 5 year previous data. So, action to be considered that if ensure that possible quality of immunization no doubt is very high and very good quality as vaccine cold chain has been maintained at everywhere. So, the thing is that if dropout is over there, then we have to play an extra effort to overcome these dropouts to mobilize these hard to reach areas directly. While delivery services indicator, so institutional delivery rate, the total number of deliveries going to be taking place at our public facilities. So that's came for institutional delivery rate for the public facility, and the same thing will be in the on the other side where it's going the number of deliveries at the home. So that also has to be taken care, but it is a negative indicator that shows that deliveries is getting conducted at the home, which is not a good if the facility is available at our every block CHCs. So we should have to move over there and we have to overcome these home deliveries. SBA, so the number of staff in the labor room trained with skill birth attendance training directly in the labor room. So that's came over here. So rational shows that institutional deliveries by SBA trained staff nurses reduces maternal mortality because a lot of information and knowledge and hands-on training is given in this SBA training. So, and that came directly in their practice. So the deaths has been reduced. So improved emergency infrastructure should be maintained, as well as the transport and referral facility. Nowadays, it's very good 10 that government has been also given provided over there. In absence of complete estimated population figure in the state, the institutional delivery performance can also be calculated by total reported delivery figure. So this is one another way that how we can calculate this, but this can be supplement one only. So action to be considered that all the staff nurses and staffs in working in the labor room must has to ensure has she has to be gone through this SBA training. So complicated delivery likewise we have discussed in the process indicator. So if PPH is going on, atonic PPH is going on, hemorrhage is going on. So based on several indicators that a triaging has to be done, and on the very time manner, it has to be identified that it is a complicated case. It is not going to happen at our facility if C-section and FRU is not available. So taking consideration of time that staff has to be referred that at considerable facility. So action to consider that to few C-section indicate that health system is putting the health of mother and child at risk as the system is not ready to handle C-section. So that's it. Uh, Staff has to identify it in a very good time so that pregnant woman who is in the complication can be referred to the nearby facilities, either FRUs or district women hospital to get that delivery conducted. Like this is a postnatal ward that There is a if you go through the WHO safe birth checklist, that pregnant woman that delivered woman has to be taken care of till 48 hours. So once the delivery has been done, so the time duration has been given the 15 minutes, 30 minutes, and 1 hour and 2 hour. That number of visit has to be done by the staff nurse in the PNC ward to the pregnant woman to check out this um, consider condition of pregnant woman as well as uh, mother as well. A lot of indicators over there. I'm not going deep into that. After completion of these four series, we can discuss more about this WHO Safe Birth checklist, including partograph as well. So this is also from post title. While family planning coverage, that contraceptive prevalence rate CPR. So on this proportion of eligible couple using family planning methods, sterilization coverage data will be also taken over here, and intrauterine device use coverage contribution will be data will be also taken over here in the HMIS. Oral contraceptive, while detailed data which has been consumed in this particular month from the healthcare facilities, these data will be taken in our HMIS, likewise condom, OCPs, as well as a proportion of spacing methods, so that all will be taken. And likewise child source slide is not exact up to this. So once the delivery has been done, so this data has to become over there. Likewise key the number of newborn breastfeed within the 1 hour, that we termed as EIBF. So that data will be also taken, that the while doing the institutional delivery, the proportion of newborn breastfed um, within the 1 hour of the birth, as well as a low birth coverage rate, and sex ratio of the birth, so number of male and female born, that the data has been also provided from the labor room. So overall, likewise key that all which we have discussed, this is overall rational for the same. So that the detailed version of previous one which we have discussed in the part. So that is NMR. mm, Neonatal mortality rate will be also going to be tracked out. So the number of neonate has been died within the 28 completed days of life per 1,000 live births. So Ashas will be going to report that key number of deaths has been happened over there. She has to report. Infant death rate, likewise key measures the number of deaths of infants under 1 year of age per 1,000 live birth. That is the definition. But specifically, rational is that key infant deaths should be reported monthly basis. So that the same thing is over here as well as in for the infant death rate. So the action to improve this, improved notification through line listing by health workers, like is from the ASHAs to the ANM of that sub-center, and then it's come to the BPM, and from BPM it's going to be reported to the DPM level. So under 5 mortality rate, that the same thing is over here for the rational and this, but the definition will be changed, that the age period will be taken to the 5 year. So PNMR, so specifically the action to be considered for PNMR key, institution with high PNMR need additional support to identify the cause of the deaths, with normally need training of neonates care technique for the healthcare personnel who is working in this that particular labor room. And the maternal mortality ratio is that key the number of deaths occurring. So what is the rationale behind this key deaths is occurring? So that the reason has to be taken out care, so that that directly reflects on the quality of care is stating from this the day of conceiveness till the completion of 9 month of period until when it's going to be delivered. So that all completes the role over there. So that overall has to be taken care, that how we are going to overcome these all. So, ANC services, during the ANC services, when the pregnant woman is coming, so several indicators has to be fulfilled and tracking has to be done. So, a blood test has to be done, that directly for the hemoglobin, and hypertension has to be checked, and with the blood, the number of anemic reported. Um, for if premium is coming with this, there is some of symptoms that on which SBA staff nurses and ANM has been trained to identify this eclampsia, and so the percentage of eclampsia identified and then referred to the CHC to manage that out. So that percentage which has to be identified, that has to be recorded. Likewise, in the coverage indicated that registration rate as well as institutional deliveries who receive the GSY benefit will come over here, and that is also taken care. So on the service delivery indicator, IPD as percentage of OPD will be taken, will be reported here. That also gives an image for monitoring parts. Operational, likewise, ki general and spinal anesthesia for the persons of AD. This is directly at the level of district hospitals and FRUs will be taken. Minor operation, dental utilization, BOR data will be also taken. As well as from lab services, HIV positive and the percentage of HIV tested, proportion of ANC women who came for ANC HIV tested, um, HIV prevalent under the pregnant woman who is seeking for the ANC care, that will be also taken care. And specific one of the category for the HIV prevalence, uh, excluding ANC women will be taken, and one is specific to the male candidates. While this is from the Department of NVBDCP, that API, what is over there, and ABER also, as well as for specific for under 5 that diarrheal incidence is coming, so that has to be taken care of. Oh, when we will discuss about the Excel sheet of all the indicator of HMIS, this data will be considered, and this will be also monitored over there. So that's it from my side as of now. For the next two part, we can discuss in the detailed version, and after that we will move at the next module, that how it's going to be happen and what is the effect and what is their effect on the different programs, specifically for and likewise NPCDCS, which has been recently name has been changed, so that we will track it out for after this. Till now, take care. Thank you. Bye.